Welcome, everybody. This session is ready to begin. Helen Figge from MedicaSoft will moderate this session. Helen, the time is yours.
Hi, everyone, and welcome. This is a very exciting day for NADO's 35th Annual Conference, and we are here to really shed light on improving data quality and mapping and technical issues. Can't stress enough the importance, particularly in what was said in our plenary session, of how important real, practical, relevant data is going to be moving forward, given what we're seeing, given the fact that models aren't really modeled very well due to poor data. And NADO hopes to change that now and moving forward. I'd like to introduce our panelists today, each subject matter experts in their own right. We have Katie Howard, Janice Bourgault, and Kevin McAvey, all who will be panelists. And what we're going to do is Katie will go first, introduce herself, where she's from. She'll do her presentation, and we will go from there. So Katie, take it away.
Thanks, Helen. My name is Katie Howard. It's not letting me share my screen. There we go. Today I'll be talking about mapping Medicare data from ResDAC into state APCDs. I'll be going through several approaches, challenges, and lessons learned. I am a data scientist at HSRI. I specialize in all payers, all claims databases and have worked in several states. Also, this presentation was made along with Kevin Rogers, who is our Senior Business Systems Analyst, and Leanne Kandura, our Director of Population Health. First, I'll be providing some background. Over the past decade, the Centers for Medicare and Medicaid Services, CMS, has approved the Medicare data for release and integration into states' all payers, all claims databases. Medicare, however, doesn't, as many of you may know, does not submit the claims in the data submission format to the state. However, states can apply for the Medicare original data as well as the Medicare Part D data. To receive this data, you have to be a qualified entity and go through their certification program. Currently, 27 entities have been approved to receive this Medicare data. So once you have applied and been approved to receive the data can come in several formats. Some states choose to only receive medical eligibility and claims, while other states elect to receive pharmacy data and eligibility along with the medical claims. The data comes from CMS in the following formats. There's a pharmacy claims PDE file that comes typically in an annual file and lags behind the medical claims. Along with that data comes the pharmacy eligibility. And I provided the technical names just for those of us that work with the data as we receive it from CMS. We then also receive the medical eligibility file. This provides information, as you'll see later in the presentation, on the Medicare Advantage as well as Medicare Original or fee-for-service. We then also receive medical claims, and this comes in 14 separate files. 17 different files. So each of the following domains receives 2 claims files. So it comes in on a claims header level and a claim line file. And so there's a separate file for professional claims, durable medical equipment, home health, hospice, inpatient, outpatient, and skilled nursing facilities. As you can imagine, these files are very complex and they have different field names within each of them. They also come in a very different format than states are used to receiving APCD information from commercial submitters. Typically, the medical claims are the most challenging to use because of the number of files that the fields are across, as well as it's in a very different format than the data that the APCDs typically receive. So typically an APCD has information at the line level and there isn't a claim header file. So some of the challenges, as you can imagine, are that they're shifting the data fields and formats from CMS, make it difficult to map into the data submission guides or intake file layouts among different state APCDs. Also, CMS provides very minimal guidance on how to integrate this data. There are extensive data dictionaries online that one can sift through, but it is hard to map it directly into the data submission guides formats. So when we're considering an approach on our side, we feel that there's 3 main approaches. There's the standalone alone, so you would use the files as they're received from CMS. There's the full integration into the APCD format. So that means that you would take the fields where possible and integrate them into the data submission guide format that you have for your specific state. And then there's partial integration, which means mapping as many of the DSG formats as possible from the Medicare data, and also allowing for additional analytic structures to transfer some of the richness of the Medicare data into the analytic database for your data users to use. So for the standalone, it's the easiest to manage from a data management perspective, but it is the most difficult to use from a data user perspective. From a data user perspective, you would need to understand the relationship between each of the files. You'd need to have a high level of expertise, and you would also, it's not quickly comparable to other APCDs. So analysts might have full control over how to analyze it, but again, it's not easily converted into a format that allows for analysis with an APCD. The full integration to an APCD submission format means, from a data management perspective, that the data are now easily extractable for external data users. And the format of the data has already been decided by the state. Some of the cons from a data management perspective is that it requires transformation of data to a line level format. And as I mentioned before, that's not the format that the CMS data come in. It also requires regular updates for changes in field names in CMS formats, and fields may not have an equivalent in the data submission format. So you can lose the richness of those data. From a data user perspective, some of the pros are that it's easily comparable with other APCD data. It requires a moderate level of expertise in CMS data. On the con side, Again, there might not be an equivalent in the CMS data to an APCD field. And also the analyst can lose individual control over how the data are transformed. So with partial integration, this allows, again, for easy extract to external data users as a pro. And the fields in the CMS data that don't have an equivalent can be integrated into the analytic data structures within your data warehouse. And I'll go through an example of this in the next section. One of the cons is that it does require the highest level of effort and quality control from a data management perspective. Specialty logic beyond what exists for the private payers who submit data to the APCD is required, and additional data structures are needed in the system. From a data user perspective, it can be very helpful because there's a standard additional fields that exist for all analysts in the system. Medicare specific data are more readily available, and nuances specific to the Medicare data can be integrated into the state's APCD. It does require a moderate to high level of expertise to use the additional fields. Some of the cons are that the data for CMS are transformed differently than other APCDs, so there may not be equivalent fields for analysis when integrating the Medicare data. And then some of the, and it can be difficult to sometimes coordinate between different data users. Now I'll go through an example. I'll be going through, the CMS eligibility data and how we look at who's eligible for Medicare Original and Medicare Advantage plans. And this is a very important analysis because we've really found that the Medicare data are complete on the Medicare Original side in the claims, but they aren't complete for the Medicare Advantage. Those complete claims really come in from the private payers. So being able to distinguish in your member eligibility who's Medicare Original and who is Medicare Advantage is key to not only using the CMS data, but also informing other analysis in the APCD. And I've included some of the complexities of the field and how it's coded when it comes from CMS. And you can see that there's a variety of combinations for who has Part A Medicare Original, who has Part B Medicare Original, and combinations thereof. They also have in the data the HMO indicator, and this indicates the variety of Medicare Advantage plans and combinations that are available through CMS. So there's a high degree of complexity in the data. When we're coding into the APCD submission format for the insurance product type, we start with the CMS fields, the buy-in and the HMO indicators. We create an intermediary calculation, which isn't visible in the end analytic unit views, but it does help with the calculation of the insurance product type field. And then we're able to code who has Medicare Part A, who has only Medicare Part D, who has Medicare Advantage, and then who does not have Medicare Advantage or Original, but only has pharmacy eligibility, which is very rare. So you can see that when we're calculating into a specific field, we aren't able to indicate on a single line both Medicare Part A and B in the insurance product type field. In the data submission guide, it's one or the other per line. And so we prioritized Medicare Part A over Medicare Part B, and we lose that richness of the data of who is also on Medicare Part B. So one way to get around that is with the partial integration. So creating a separate indicator in an analytics view of who has Medicare Part B, because that's not a standard part of states' APCD intake fields, but it is very important when analyzing APCD data and especially Medicare data. And so through creating analytic structure, we can decide that we want to have a separate indicator flag for Medicare Part B. And that allows all the analysts to access it without having to go through all of the different claims eligibility files. And it really helps maintain that richness of the CMS data. So how we, in terms of lessons learned on our end, we have really felt like that we should do a blend of the three different approaches. So we have the base tables that contain all the data as received from CMS. So if you have a data user that's a real go-getter within your system, they can access all those detailed tables in all of the different claims, and they can integrate that into their analysis. We then also have the valid views, which contains the CMS data in the standard submission format. So that represents the full integration. And then we have analytic that provide additional access to CMS specific fields in a standard format. And with this approach, you're able to link between each of the different approaches to the CMS data and really standardize your approach and have flexibility. And so I'll just wrap it up real quickly. So some best practices when doing this is really clear documentation, showing how each file type is mapped, regular updates to ensure all relevant fields are added from the CMS data and to monitor changes. Just maintaining expertise on Medicare data for your data management team and data users is key. And also states may want to partner on mapping CMS data to the common data layout. And that's it. Thank you so much.
Great. Thanks, Katie, so much for that. That is phenomenal. Janice, how about it? Understanding how billing practices impact the APCD data.
Hey, Helen, just a quick reminder to everybody, if you have questions, please submit them through the Q&A bar on the side. We'll be able to watch this easier. Thank you, everyone.
Good afternoon, everyone. I just want to make sure everyone can hear me and see my presentation.
Yes, you sound great.
Okay. Yes, thank you, Janice.
All right. So I'm Janice Bourgault, Director of Product and Process Development here at Onpoint. And today I'd like to go over how billing practices impact APCD data. I'm a certified professional biller and coder, so this topic actually excites me. I'm a billing data geek, and I hope you also find it interesting. So oftentimes when working with healthcare data, we see data that looks odd and actually may look like a potential data quality issue. You actually may end up excluding those records from analysis. However, it actually might be accurate data reported based on proper billing practices. So I'd like to go over a few of those examples. And let's see. Here we go. So let's start with facility claims. And when you may or may not see HCPCS and CPT codes reported on them. So here's our UBO4 facility claim. I'm a visual person, so like to provide the visual, and we'll be focusing on that middle section, service lines. For illustration purposes, I've actually combined an inpatient and outpatient service line on this one claim form. So the top row, the room and board revenue code, you could see the third column. I don't know if you could see the tiny print, but the column header is HCPCS, rate, or HIPS code. And for inpatient claims, you are seeing a rate. The bottom record, the chemistry test, is actually an outpatient claim. And in this case, you are seeing that CPT code, the lab test that actually goes with that revenue code. The reason for this is actually the guidelines when using the UBO4 or the facility claims. So here's an example. So here's an example or an excerpt from the UBO4 manual. And you could see this is actually our room and board revenue code. And off to the right, they include a column called HCPCS. And in this case, it's no. What this column tells you is whether a HCPCS or CPT code, it's guidelines on whether those codes are reported when this revenue code is used for outpatient claims specifically. In this case, it's a inpatient room and board revenue code. So the HCPCS is a no. And I'm trying to scroll down. Okay. How do you scroll down? I'm sorry, having technical difficulties. All right. Not working.
Norm.
So
I got it. I got it. So here's the lab example that we saw on that outpatient service line. And here you could see the outpatient revenue code. The HCPCS column is listed as a Y. So in these cases, you would expect to see a CPT or HCPCS code on outpatient claims when these revenue codes are reported. I've also included emergency room as another example. And again, that HCPCS code is flagged as a yes. So you would expect to see those codes reported on those service lines, again, just for outpatient claims. And so that's why you may, when working with facility claims, you won't see HCPCS and CPTs reported on inpatient claims, but you would see them on outpatient claims. Next, I'd like to look at professional claims and why you may see variable data on each service line within the same claim. So here's our CMS 1500, and we'll be focusing on the service line area at the bottom and also that diagnosis area. So in the middle here, you have your CPTs and HCPCS, your charges, and your units, which of course varies for every service line within a professional claim. But I've also highlighted some other sections in yellow that because it's reported at a service line level, you may have variable information all within the same claim. So that being the dates of service, you can have different dates of service on a professional claim. Not very often, but you could actually have different place of service codes on a professional claim. And off to the right, you could see that the rendering provider can actually be reported at a service line level. So you may have different rendering providers all within one professional claim. Next, I want to look at the diagnosis reported on professional claims. So how this is set up, at the top here on field locators 21A, B, and C, I've highlighted the diagnosis codes. And on each service line, I've highlighted the applicable diagnosis pointer that's used. And how this works is on service line 1, diagnosis A is the diagnosis that's applicable for that service line. For the next 2, diagnosis B is applicable. And for service lines 4 and 5, diagnosis C is applicable. So how this impacts our data. So depending on how the payer stores the data, you actually may be seeing every single diagnosis on every single service line, which I have here on scenario 1. But some payers actually store the data just using the diagnosis that was applicable for that service line as provided in that diagnosis pointer information. And so you actually may receive or see in the APCD data that there's a different diagnosis for each one of the service lines. So again, keep that in mind when working with the data. Next, I'd like to go over when admission dates and first dates of service differ. And let's just start right out with our usual scenario. So here is an inpatient stay where a patient was an inpatient for over the course of 3 months. You can see the admission date on all of these interim claims is January 5th, the actual admission date, but the from date reflects the first day of the month for all of these interim claims. So this we see very often. Other scenarios that you may have run into, you actually may have seen where the first service date or the from date is prior to the admit date, which you would think, how can you have a service prior to being admitted? This actually falls under Medicare billing rules, where an outpatient service provided within 72 hours prior to admission are included on the inpatient claim. You also would see this on commercial claims or any payers that follow Medicare billing rules. So this type of scenario might be, I went for blood tests 2 days prior or 3 days prior to admission to the hospital. Those lab tests would be included on that inpatient claim and would have a from date or first service date prior to the admit date. So data looks odd, but it's true billing practices. Another scenario, a member or patient could be in the ED room prior to admission. So again, their ED is considered an outpatient service. So that first service date may be prior to the admit date. Oftentimes working in claims, you may see records that look like duplicates. And so in these scenarios, I highly recommend looking at the use of the modifiers. So this first example is 2 E&M visits on one claim, same data service, same provider. This is actually proper billing practice. This example, I'll use myself as an example. I went in for my annual preventive visit. So that's my first service line here. But while I was there, I complained of a sore throat. The provider did treat me for my sore throat. And so the provider is able to bill that as a separate office visit. You can see the use of the modifier 25, letting the payer know that this is not a duplicate service and it truly is a separate E&M code. So you will see these scenarios. Using COVID as an example, interim guidelines for testing and getting specimens for COVID testing. The recommendation was to take 2 specimens, one behind the nose and one at the back of the mouth. Because there were 2 specimens, actually you would see the same CPT code reported twice. Again, looking at your modifiers, one of these should have modifier 59 saying it's a distinct service and not a duplicate. Radiology, many of you may be familiar with these modifier codes. So again, you may see the same CPT codes, same data service. You want to look at your modifiers. So your modifier 26 is the professional portion of the claim where the provider or radiologist is reading the test. And the TC is the technical, the actual test itself. You may actually also see where a hospital provides both those services where there is no modifier. This is the global code and includes both the reading and the test. Another example, you also may see 2 surgeries happened on the same day, 2 different providers. Again, look at your modifiers. In this case, is a modifier 80, designating that Dr. John Snow was the assistant to the surgery. And lastly, I just wanted to look at quantity amounts that we see in the APCD, and also what I call penny charges or 1 cent charges. So quantities. Quantities are based on the description of your CPT or HCPCS codes. So for example, your 99213 office visit, in the description, the unit for this CPT code is a visit. So you're seeing the quantity of 1 reported, as opposed to a therapy visit where the unit is in 15 minutes. So 1 visit may actually have a quantity of 3. In addition, you may see quantities in the hundreds or even thousands. Again, that is all based off of your CPT or HCPCS code. And you can see in these examples, your 240, a quantity of 240 is based on minutes for anesthesia, and the ones in the thousands are miles due to ambulance services. And lastly, the 1 cent charges. Oftentimes we get questions on this as far as, is this accurate? Is the decimal in the wrong place? These are actually actual charge amounts. The reason for this is if you think about a billing application, charges will not show up on a claim unless there's a balance. And so providers will use this when they need to report a non-billable charge on a claim, such as state-supplied vaccinations or quality CPT codes, for example. They'll put that 1 cent charge so that there is a balance and it will show up on a claim. So those are not, it's not incorrect data. Again, you will see penny charges. So in summary, understanding billing practices will not only help you distinguish between data quality issues and accurate reporting of the data, but will also help you use healthcare data properly and to its fullest potential. And I'll pass it to Kevin.
Thank you. Thanks, Janice. And our last session before we entertain some questions is from Kevin McAvey and from Manatt. And make sure everyone knows where everyone is from, Janice and Katie. What is the matter with encounter data, common issues, and actionable state strategies for improving a critical data resource? Kevin, take it away.
Yeah, great. Thank you so much, Helen, and thank you all for joining us. I'm scrolling through the list of everyone's name on the list. We have so many friends and former colleagues and folks from the NATO community joining today. And I'm so glad during this time when we're all physically separated, we can still find a way to come together as a community and share what we're seeing and what we're learning. And Janice and Katie, thank you for taking the time to share your work with us today. It's truly fascinating. My name is Kevin McAvey. I am currently coming to you from my attic. And if you hear something that sounds like a bird in the background, that's actually my son doing whatever it is he's doing. But these are the days we're in, and again, I'm thrilled to be here with you. I'm a senior manager at Manatt Health. I was previously with the Center for Health Information and Analysis, which is, I think 4 years ago, 4 years ago now. And that's where I learned so much and about the importance of APCD data and became a true believer in what we can do with the data assets that we have available to us at the state level. I've continued that work working with states and providers and plans to think through their what we call data strategies, like how they can use clinical data, claims data, encounter data, ADT data, and most recently and pressingly, their EPI data, their surveillance data, their testing data, and bring it all together, link it to and analyze it to inform their program and policy goals. And so I have a deck that I'm going to talk through really quickly today, not necessarily focusing on our late-breaking COVID work, but some work that we're doing out in California right now, working with the Department of Healthcare Services and the Department of Managed Healthcare and via HealthNet to really talk through what we are seeing as it relates to encounter data in a highly delegated market, and just some things to think about when we're thinking about APCD data and the data we have in there, its quality, and how to properly frame it when we're reporting it. 3 things I just want to say off the top of the bat, because we're going to go into some high-level details here on the California example, but for everyone online, and I'm hearing echoes of Lori and Deb from Massachusetts in my head, like encounter data aren't claims data. They're very similar. But the claims data has like this wonderful thing where you have a one-to-one requirement, like you submit a claim and you can get a payment. When you don't have that direct incentive, you also lose that direct incentive to make sure that you're populating a similar record with verifiable, usable information. There are different reporting requirements for encounter data up and downstream, and I think when we look at the data we have available to us, we just have to really understand where it comes from and some of the root causes of the quality issues that encounter data can face. APCDs, all payer claims databases, probably for some lines of business actually have more encounter data in them than claims data, making it particularly important for us as we think about using our readily available data assets. But APCDs and agencies and health data organizations generally, I think, can play a really key role in their ecosystems.
Kevin, do you have slides?
I'm getting there, Helen.
Do you have slides that you want to put up to start this year's presentation?
Yeah, I'll pull up the slides, but I'm just talking at a high level. APCDs and health data organizations can play a key role here as conveners, really helping folks to come together in the ecosystem around the issues that are faced around data standardization and developing solutions, and certainly with setting benchmarks across different lines of business and for different populations, which can help all your organizations that are submitting data to you better understand what data, ironically, they might be missing from the experiences of their peers, which they don't have the opportunity to see. So as part of this work, I was joined by my colleagues Jonah Froelich and Lamont DuPont, and again, our work wouldn't have been possible without HealthNet and the key agencies in California. But I want to just level set here very quickly around what encounter data are. They're records of services rendered in a capitated environment by providers or plans and reported up the chain. They should have, in many instances, most instances, hopefully in one day, all instances, all the same data that we have for the claims that we receive. But they're equally as important in helping all of the participants in this ecosystem, from states, plans, providers, care managers, to really understand who they're caring for and the type of data and the type of services that are rendered and requirements for those services. There are many rules in place right now underlying the importance of encounter data at the federal level. I'm not going to go through all of this, including the managed care rule and the recent interoperability rules. If you have any questions on these rules, please just reach out to me. Obviously, I probably talk too much about this stuff, and I'm just overeager right now. But even at the state level, most states have individual encounter data reporting requirements, all rolling up to the EQRO process that they have to undertake before submitting up to CMS. California has several rate setting and is aiming to actually set managed care plan rates using encounter data that they receive. Again, kind of tying back to that incentive, at least at the highest reporting levels. Directed payments in California are directed by the encounter data they receive, and in plans and providers, encounter data is critical for HEDIS scores and reporting. But data quality, again, is an issue. When you think about in this little pretty diagram here, some of the more complicated and delegated markets we face, it's like this really bad game of telephone from when you start at the provider and even at the front desk when data is first inputted into the system and eventually rolled up from your clinical platform into your billing system, which may be one and the same or different. The data can potentially get corrupted at various points. And for some systems, we have plans capitating to other plans, providers capitating to other providers. It, again, becomes a really bad game of telephone that can seriously impact the ultimate quality of the integrity, completeness of the data you receive at the end of the day. So, and Helen, if you give me a shout once I'm starting to run out of time here. I'm not going to talk through any of this, but I wanted to provide you all with as much material as possible, and this will be provided after the session. And I'm happy to talk about it more. But generally, when we're thinking about the data that we have access to and where the initial quality concerns come into play, at the very base provider level, you have significant differences in awareness of encounter data importance. You have significant turnover in the staff who are actually coding the data, and you have often antiquated and rigid EHR systems that have been in place for a long time that don't necessarily keep up to the same data standards. And so again, when it gets rolled up, you don't often get the most complete and accurate data for use. You also have in this green box that you see on the screen clearinghouses, or these intermediaries, which are critical facilitators in our system, often for smaller practices or even larger practices, making sure that we're vetting data appropriately, cleaning it up and reporting it upstream. But like introducing intermediaries into a system can actually affect data quality, ironically, in some ways that are not helpful. For instance, often the IDs that can become tracing links back to the original provider are dropped, and so it affects error traceability. And so once you get to the managed care plan level, if they're finding that there's data missing for particular populations, it's very hard to ultimately get back to where that error actually occurred. And then finally, you have issues that arise between when the state submits encounter data, for instance, in our project with managed care plans. The requirements aren't always crystal clear from CMS on what is required to be submitted and what is not. And so you again result in disparities there. Payments and incentives, a cross-cutting issue, communication, feedback, and traceability up and down the system as well. So in California, what we did and undertook in our project here is we in 3 phases of work. The first, we helped to identify what some of the core encounter data reporting issues for the Medi-Cal program were, what solutions they required, and on our instance, we identified governance, data standardization, technology training, and technical assistance as those core areas. And then across our year process, worked with stakeholders from payers, providers, intermediaries across the system, the state, to develop actionable solutions to really make measurable difference in the environment. And sometimes that difference can be substantial. One anecdote very quickly is a particular plan noted that they started pulling in clinical data from their local HIE to compare what they were receiving in terms of billing data, claims data or encounter data from their downstream providers. And they found up to a 20% difference in data that they didn't receive. And that's not even talking about the complete accuracy of the data that you did receive, particularly as it relates to diagnosis codes and other patient factors. We're helping the state right now think through 3 solution areas and to improve encounter data going forward, including establishing an overarching governance entity, which I think APCD-like agencies can play a key role in helping to facilitate in their own individual markets, overcoming key critical data standardization challenges such as local codes and their unique reporting, and then working very closely with providers on training and technical assistance. All of this was provided through $50 million that HealthNet agreed to spend in the market to improve encounter data reporting over the course of 5 years in exchange for a merger that happened probably 2 or 3 years ago. So this was very much a public-private partnership and collaboration, and is already resulting in improved encounter data in the system as stakeholders become more aware of the problems and work internally to rectify them. And we look forward to helping the state and all of our friends out in California advance these goals that much further. I've included some additional recommendations here just to give you a flavor of what's being implemented and some of the errors that are being faced by plans and providers in California. Again, I won't go through all of these, but I'm happy to talk more in the Q&A around the types of actual technical encounter data challenges that our upstream plans and the state has noted and faced. Newborn identification, duplications, visit encounter reconciliation. These are all problems that various plans have reported facing, and that all APCD data, to the extent you have delegated markets, and I'm not just talking about with Medicaid, but other lines of business as well, really understanding that where the data is coming from and what it does and does not represent when it comes to the payment fields, for example, I think are important. Our reporting footnotes, and you can actually help in some instances resolve some of the issues that are identified. And I won't go through all of these, but I just want to pause, say thank you again for allowing me the time to share some of our work. I'll be back next week to share some more about the cost benchmarking program, and I'll stop now and pass it back to Helen to facilitate some questions. Thank you.
Thank you, Kevin, and thanks everyone. Very enlightening points of view from some subject matter experts, and it's again, we're talking about the data, the relevance of it, and the practicality of it. And it's interesting to note that the ONC Interoperability Advisory Report of 2020 said FHIR-based standards are the way that we'll be moving forward with data, and being able to handle that effortlessly and seamlessly as I think going to be something that is needed to be undertaken. And most importantly, I think the question everyone needs to ask is, how long has someone been able to support FHIR-based standards? Because we can't have places making it as we go. It's either there or not. So I wanted to add that level for data integrity and data practicability, if there's such a word. So I want to get into some of the questions, and they're in no particular order. And if I direct it to one of our panelists, then by all means, everyone join in. And if everyone wants to show their face with the name, so we can have our discussion, would be great. Janice, the first question I think will go to you. What are the recommendations on how to effectively discover the rules that should apply when detecting data defects? Can you shed some light on that, please?
Sure. Probably won't like the answer, but I think the bulk of it comes from experience. As you go through this, where I've, besides the, just having practical billing experience, I turn to CMS's website quite a bit. They provide quite a bit of information about billing practices, et cetera, and a number of commercial submitters do follow their guidelines. You could Google it. Hopefully your APCD provides you with reference tables. So like those modifiers I was showing, hopefully you have a reference table that gives you a description of those modifiers. Billing websites, the new website, etc. So Google can be your best friend, and I think the CMS website is a good place to turn also.
Wonderful, wonderful. Kevin, if you could stop sharing your slides or your screen, I think maybe people will see the faces. I don't know, something popped up, but I want to keep going with the questions. And this one actually is directed to you. As you mentioned, measurable distances in the data, are they achieved by corrections of the data user side or by making data corrections upstream? Can you advise on that, please?
Yeah, so I think that where we're seeing corrections or that gap narrowing, it's a partnership both oftentimes both with the plan and the delegated provider. A lot of times the plan might not even know where the errors are occurring. So one of the most high functioning systems that we've seen so far is where there are very clear and actionable feedback loops that can go downstream to help providers understand where there are errors within the encounter data record, or where there might be completeness gaps. And some of those gaps could be identified both from previous experience with that provider, as well as benchmarking. It would be another example of helping to identify those gaps.
So I'm sort of hearing the fact that this is more just as much of a technical support as an art of being able to really understand this in the sense of user experience. Would that be fair to say from a data perspective?
Yeah, I think two big parts that the two big themes that came back to me is, one, there's a lot of training and education that's needed up and downstream. The second is we need to make sure that we are communicating using the technology we have available up and downstream to kind of reinforce those learned messages.
And I think that's very important, Kevin, because that is exactly the mission of NATO. You know, we are under Norm's auspices. We are going under a challenge of greatness and realizing the data and all the opportunities we have to accentuate the positives and all of our subject matter experts, as you see here today, but also what's out there that's needed. You're going to see some really cool things coming out of NATO in the very near future as we grow. So this is a really exciting time. It's an unfortunate time about data, because I can't stress enough the data and the mismodeling that's out there that has caused such, and I'm speaking as a pharmacist, such hysteria of our lives. And had we have had better data early on and knew what we would zoom in on, I think it would have made a world of difference around the world. So I must make that as a statement. Katie, I want to really point to some thought on you. At the end of your presentation, you indicated a path forward that could consist of states partnering to map and utilize CMS Medicare data. How would that practically look in your thoughts?
Sure. So we're at HSRA very supportive of open source formatting, and I think NATO is a great platform for coordinating the work of mapping the CMS data to the common data layout. And that can really be a basis for showing states how that integration can work to a common format. And I think that group could also be a platform for ensuring that we have a voice at the national level with CMS when they're making formatting changes. So we are fully in support of something being open source, and the common data layout just provides a good national opportunity for really showing how those data map into an APCD layout.
Janice, do you want to add to that? And then Kevin, your thoughts? I think that's a very interesting observation and thought that I'd like to expand on.
Sure. I echo everything Katie said as far as CDL being a great platform to map the Medicare data. Katie also mentioned some data elements that are currently not included in APCD collections. They're Medicare specific. So, you know, adding those elements to a CDL layout, for example, would be great to do along with those mapping specifications. So,
Kevin, what are your thoughts?
Yeah, I think the common data layout is, I wish it encompassed everything and it was standard across the country. I think there are only so many lines on a claim field. And while each state has individual fields that they might need added, I think the more we move holistically to an integrated aligned format, I think the better for everyone's individual goals across states.
So with specific pieces of data, CMS data, and the elements, depending upon which path an APCD chooses, can you somehow communicate in practical and level sense the options and clearly what decision makers should think when choosing that path, if that makes sense? Katie?
Sure. So I think that one thing that we really try to do is to go in and learn how the analysts are currently using the data and what analytic structures exist and map to those first, and then guide analysts in figuring out if there's any other common ways that they're really looking at the data to map into a common analytic view for them to look at. And I think someone asked about examples of what would it mean for a full integration versus a partial. And originally I had wanted to talk about integrating the medical claims payment information because that is the most complex, but that would take an hour. And really because the APCD data are often at the line level, there isn't, for example, payment at the line level necessarily in the inpatient line level data. So you need a data structure that allows for that header information about what the overall payment was for the inpatient claim to come through for analysts. And so those are some of the things that we really consider and what kind of data structures we're going to make so you get that richness of the payment data, for example, when bringing it into the APCD format.
Janice, Kevin, would you like to add anything to that thought? If not, it's sort of kind of.
May I add one thing?
Yeah, sure, Kevin, go ahead.
Yeah, for us, it's so exciting to see the Medicare data being put to good use. It always starts with like, what are you trying to use it for? And then being able to understand like what data is available and how you can link it appropriately to the data source. You might already have analytic processes like Katie was saying to build upon. But like I think that one of the things that I suffer from and a lot of us do, and I think APCDs do in general, is we're collecting so much data. We have collected so much data, but like really thinking through how we want to put a more limited subset to use.
Yeah, and I would just also add, to fully integrate this with commercial and Medicaid data, much of the information is the same. It's claims data, but also looking at what Medicare specific fields are needed for analysis. Katie went over like your buy-in and your Medicare Advantage codes or your dual eligibility codes, things like that researchers will need that additional information. So it's pulling in what you can so it can be fully integrated with commercial data, but making sure you include the additional data elements that are nuanced to Medicare specific.
So, and if we don't get to your question, please send it to Norm, and we will ensure that we answer your question. But from a philosophical standpoint, in the simplest terms, why are medical claims in CMS the most challenging to use? We see it, and it just wraps around everyone's head, and we still don't have it right. If each of you can just give your philosophical thought on that, and is there any nirvana answer to it? Katie? Kevin? Kevin, you're silent.
I think honestly, it's just very hard when you have fields spread across 14 files, and they can often be very different. And so gaining the expertise to analyze that data can be a large upfront cost for any organization. So I think when we come together, and map it to the common data layout, then we're sharing that expertise that takes a long time individually to build up. So that's my nirvana answer.
Yeah. I'll add, just understanding Medicare billing practices and how they adjudicate the claims also helps you understand or better understand how to map the data and also how to use their data. So yeah, understanding Medicare billing, very important.
Yeah, I guess the only two things I'll add is even looking at like a Medicare, Medicaid duals population, it's such a heterogeneous population. It's not like a population. So having that program context and knowledge is just so important before you approach the data, so you can understand where there are data quality concerns. And the other thing, building on something that Katie mentioned, not only like, I think we'd be better off if we had a quarter of the data that we did right now, and that data was kind of tested, vetted, verified, and had a unique identifier that could be traced across. And I'm not just talking about like at the state health data organization level, but even between Medicare and Medicaid. And I think that's on the agenda, hopefully.
And I think the last question, I think it's a big white elephant in the room, COVID billing. I'm from New York State, and everybody in New York City for the last 4 months has died of COVID, even though they got bit by their dog and they, were comatose for that. What's your thought on how can we streamline this through these various agencies to get it more succinct? There's money for COVID, and we're seeing maybe not an abuse of it, but an overextension of that. How do we wrap our heads around it so we can get back to true health care where we're missing diagnosis of cancers because people are fearful of being to the hospital, elective surgeries possibly for biopsies, all those things. In 30 seconds, each of you give your thoughts on that, and then we'll wrap it up. Katie?
I'm not sure. It's a little bit outside of my expertise, so I'll let someone else go first.
Janice? There's no correct answer, I'm sure, because we haven't figured it out yet, right?
Yeah, and I'm not really sure where to start. That's a big question to respond to in 30 seconds.
There's no magic bullet or pearl in your repertoire. Is that basically what I'm hearing?
I would agree with that, yes.
Kevin?
Yeah, so I think we have CARES Act funding that runs through the end of the year. And I think that like some of the states that we're working with right now are using that funding to help create bridges between data silos that have not previously existed. For example, in North Carolina, we're working with their HIE and Health Connects and the Department of Health and Human Services, specifically DPH, to exchange clinical and patient demographic information so that it can be actionable to the right people at the right time. Similarly, for testing, tracing, making sure that that data is actually getting to the places it needs to go is one way. There's also some 90-10 funding opportunities for Medicaid that can be used to further advance data sets. And
thank you. Well, on behalf of NATO and this phenomenal panel, we would like to thank you for attending this event. And we hope that you enjoy the rest of the conference. Spread the word about NATO, because at the end of the day, we will find more and more healthcare is going to be very based on data, truly, for once, relevant, practical data. And NATO's mission is to do just that. So on behalf of everyone's herein, we would like to thank you and continue success in making the world a better place that we all live in. Thank you, everyone. And make sure you fill out the surveys and questionnaires, whatever you get, because Norm and Charles really have done a phenomenal job pulling this together. We've had record numbers, and we really want your feedback because it's really measurable, and we really want to make a difference. Norm, would you like to say anything else, or are we set? There's Charles.
Yes, thank you, everyone. We were just actually getting ready for the daily puzzle meetup, and we're hoping that everybody has had a chance to download the puzzle and make a couple of friends. This one's not a very challenging puzzle today, and we hope that everybody can find 3 or 4 friends, or maybe a dozen, and connect with everybody. But thank you all for your time.
Thank you. Bye, everyone.
All right, thank you.